Hello and welcome to this special teaching session. Each year, members of this team visit BKL Walla Waka Hospital and we should be there with you now, but due to the awful COVID pandemic, we were unable to join you in person. This led to a lot of upset people here in the UK, so we decided that we would try to keep some degree of normality and visit you remotely. This week we have some excellent speakers talking on a wide range of subjects. These include radiology, anaesthesia and critical care, urology, orthopaedics, medicine and paediatrics. To keep things running smoothly and to maximise the use of our time together, please send us your question via WhatsApp on +44 333 303 0975. That number is scrolling across the bottom of the screen, and you can also scan the QR code at the top left of the screen or send us a message via the chat on YouTube. Because of today's packed programme, we won't have time to answer questions live, but we will compile questions and answers and send them back out to you. In the meantime, I'm going to hand over to today's speakers, Sarah and Caitlin, but please do send in your questions and we really hope you enjoy today's programme. Thank you.
Hello, my name is Sarah Scott and I'm an anaesthetic and intensive care trainee in the United Kingdom, currently working in Gateshead. I'm going to talk about mechanical ventilation for about 20 minutes. As this is an absolutely enormous topic, I'm only going to have time to pick out a few key points. So I'm going to look briefly at which patients need to be ventilated, have a look at some of the modes available and what you need to think about when you're setting up your ventilator, a few tips for troubleshooting if you run into difficulties, a small section about weaning and a little bit about complications associated with mechanical ventilation. There are a huge number of resources available, so I've popped a few of these at the end on the final slide, which you might find useful to look into. So firstly, which patients need to be mechanically ventilated? It's quite a common reason for admission to critical care. In a 2011 paper, it was estimated that in UK practice, 55% of admissions to critical care are already mechanically ventilated, and within 24 hours this increases to 68%. And there can be many reasons for this, but I was just thinking about it in broad brushstrokes. So thinking about airway protection, so this might be due to trauma or traumatic brain injury, patients who are post-ictal, or patients who are intoxicated or who may have overdosed on either medication or recreational drugs. Thinking about then respiratory failure or having inadequate oxygenation, so there can be many reasons for this to have occurred, thinking like sepsis or respiratory failure secondary to pneumonia or ARDS for any reason. Then thinking about how you might want to control some of the patient gases, so thinking about particularly carbon dioxide and in traumatic brain injuries where it's quite important to maintain control over the patient's PCO2. So moving on to talking about modes of ventilation. This is quite a difficult area because every company which makes ventilators uses different terminology and there are so many different brands available that it would be impossible to talk about them all and there'd be such overlap. So I found this picture which gives you a fairly good overview. So broadly speaking, we can think about things as either volume or pressure controlled. And then we can look further into it and decide if they are mandated by the ventilator or whether they are initiated by the patient and the ventilator will kick in effectively if the patient doesn't generate their own inspiratory effort. And this is another useful picture that I found, which again breaks it down into volume ventilation, pressure ventilation, some dual modes which can incorporate both aspects, and then some newer modes, which I'm not going to talk about, but there are plenty of papers available, particularly on the British Journal of Anaesthesia's educational supplement, which are available online and worth having a look at if you want to look more deeply into these sort of fancier modes. So first of all, I'm going to talk about volume control ventilation. And it does what it says on the tin effectively. You select the required tidal volume to be delivered to the patient. And this is delivered with a constant inspiratory flow during inspiration until the entire volume has been delivered. It will then reach a peak inspiratory pressure, and if it's reached the required volume to be administered to the patient, then there may be an inspiratory pause where there's the continued pressure, but there isn't any further volume delivered. When you're choosing the volume to set, it's quite important that you think about this in relation to what the individual patient needs. So there's no sort of set, an adult needs X mils. You think about it really in terms of their predicted body weight. So you can work out their predicted body weight from their height, but that's not always easy to do. So we often use demispan, which is where you measure from the sternal notch to the base of the middle finger, as shown in the diagram. And then there are plenty of tables available where you can work out what the patient's predicted body weight should be. And there are variations in volume, and it is constantly debated in the literature, but generally we think about 6 to 8 mils per kilogram. You can then set the flow rate on your ventilator. If you set a high flow rate, it then very quickly delivers that volume that you've asked it to deliver, but depending on your respiratory rate, there may well be an inspiratory pause. And this means that if you have lung units where the alveoli have a fast or a low time constant, there's a potential that they're going to start over-distending. And if you have units with a slower time constant, then these will delay filling, so you can end up with slightly unequal distribution of your breaths. However, if you set your flow rate low, you might not actually have been able to deliver the entire tidal volume in the time you've allowed for your inspiratory time. So it's important when you're setting your ventilator to think about your respiratory rate and also to look at the ratio of inspiration to expiration and make sure that that's something sensible. So in health, we generally spend 1/3 of each breath cycle in inspiration and 2/3 in expiration. We can manipulate this on the ventilator, but it's important to check that when you do manipulate it, that you've left something sensible and not given them sort of 0.1 of a second to breathe in, which is going to lead to very high pressures. So this is just a bit of an overview of what we've talked about. So at point A, you can see that gas is delivered at an increasing pressure at the start. So that's the inspiratory flow in A and B. So it's the line, the diagonal line. It reaches a peak at point C, which is the peak airway pressure. And at that point, the volume that you wanted to deliver has been delivered. So there is an inspiratory pause, which is marked in the little gap in D. And at that point, there is no fresh gas flow, but there is still the plateau pressure applied, which is marked out by E in the top picture. Then the triangle in F represents expiration. And at G, this is where the you sort of get an exponential curve below the baseline, which depends on the resistance and the compliance of the alveoli. So the ones with fast time constants will empty first, and that is marked out by G. And then at point I, there is no further flow, and this represents end expiration. So moving on then to talk about pressure-controlled ventilation. So again, as indicated by the name, it's where you set the peak airway pressure required. So with this, you're going to have variable tidal volumes. And the tidal volumes you achieve will depend on the compliance of the patient's lungs and any changes in resistance. So if you have really low compliant lungs or very high resistance, you're going to have a reduced reduced volume delivered to the patient. So you need to think about setting alarm limits. I mean, you will do on the volume controlled settings as well, because you don't want to reach massively high pressures to achieve that. But for pressure control, it's important to think about setting your volumes for the tidal volume. So if they have very, very highly resistant lungs, so for example, a patient perhaps who's got asthma, then you might want to think about setting a low tidal volume alarm to check that you're actually administering what you want. Or for a patient with highly compliant lungs, think about setting a high tidal volume alarm, because it's going to be very easy to overinflate these lungs. So this is a graph just demonstrating the difference between the pressure controlled and the volume controlled. So you can see the pressure is a square waveform at the top, and that continues throughout the respiratory cycle, whereas you have a decreasing exponential for the flow in inspiration and in expiration. So if you're not sure what mode the patient is of ventilation that the patient's on, you can look at these waveforms and it'll give you an indication. So looking then at the advantages and disadvantages of each mode, so we have mentioned some of these. So thinking firstly about volume controlled ventilation, you're setting the tidal volume you want, so it's going to deliver that tidal volume. And you can potentially have better control of the patient's PaCO2 with this mode. But the disadvantage, as we've talked about, is that you can have very high airway pressures, which can lead to an acute lung injury. So again, the importance of alarms has to be stressed. And you can't compensate for leaks. So if there is a disconnection or there's a huge leak around your cuff, the ventilator will continue to deliver that volume that you've preset, but the patient's not actually receiving it. So you just have to be quite mindful that keep an eye out for leaks, otherwise what you think you're delivering to the patient isn't actually happening. Then looking at pressure controlled ventilation, you have the advantage then of you setting your peak pressures so you can reduce those to reduce the risk of barotrauma. There's decelerating flow, which can improve gas exchange, and you do have compensation for leaks, so it will continue to deliver that pressure irrespective of a leak, so you should be able to deliver more flow to the patient. And you can have more homogeneous ventilation due to this square waveform pattern. However, if the patient's lung compliance or resistance changes, you can have hypo or hyperventilation. So it's really key to set alarms and also to constantly to be monitoring your patient. So alarms are only so good. You need to have someone there who's available, one, to respond to alarms, but also to start observing any changes. I'm going to mention briefly a little bit about biphasic positive airway pressure. This is one of those terms that can be used interchangeably with others, and you may have come across the term BiPAP, which is bi-level positive airway pressure. That's a branded term, so we're going to use biphasic in this particular talk. So for this, you can select the peak airway pressure, which is your high pressure, your PEEP, which is your positive end expiratory pressure, which is your low pressure. You choose the respiratory rate, and again you choose your respiratory time and your inspiration to expiration ratio. Again, you would be choosing these with all the other modes as well. So the ventilator will then cycle between the low and high pressure levels. If the patient makes absolutely no attempt to breathe, this is effectively pressure controlled ventilation. However, with biphasic positive airway pressure, the patient is able to spontaneously breathe, and the gas flow will increase from basal flow by in response to the patient's inspiratory effort. The changing of flow rates maintains the airway pressure as close to the preset values as possible, and as I've mentioned, if the patient doesn't make any effort, this is the same as pressure control ventilation. But if the patient's lightly sedated or starting to put in their own breaths, then they can breathe at each pressure level without pressure support. So this is just a little graph to indicate this. So you can see at the top you've got your high pressure, along the bottom you've got your low pressure, and in the middle the mean pressure. So I'm going to mention briefly patient support or assisted spontaneous breathing. So this is where each breath is triggered by an inspiratory effort to a preset pressure level. You get a decelerating flow pattern during inspiration, and that means that your preset pressure level is quickly achieved and maintained. The patient is triggering and terminating each assisted breath, and this will be dependent on their respiratory pattern, and they determine the respiratory pattern, the frequency and the duration of each breath. And the tidal volume you obtain will really depend on the patient's lung compliance. The machine will cycle from inspiration to expiration, and this is triggered when the inspiratory flow rate falls. And when the flow rate's falling, that's indicating the beginning of the respiratory muscles going into relaxation. And the amount of fall in the inspiratory flow rate will depend on the ventilator. So it will detect something between 10 and 40% of a fall in flow rate, and that will then trigger expiration. This is a sort of flexible mode of ventilation, and it allows you to fully support the patient but allow early spontaneous breathing, and it also can be used to support the patient when you're weaning, and some models of ventilator will use this to help wean the patient effectively, will set its own weaning programme. And this is just a graph to indicate what we've just talked about. So again, you can see the square wave pressure at the top, and then you can see the inspiratory flow. As it starts to decelerate, then you get to a point where it then triggers expiration. So many of these modes of ventilation can be used together, and I just thought I would pop this particular picture in because I thought it was quite a nice summary of what a controlled breath is, what an assisted breath is, and what a supported breath is. So in a controlled breath, the patient is doing absolutely no work whatsoever, and the ventilator is doing all of the work. So that's just the equivalent of somebody hanging on a monkey bar or a rail and not doing anything. In an assisted breath, the patient's able to start the work, but the ventilator takes over. And then in a supported breath, the patient is doing most of the work and the ventilator just adds in the last little bit to finish. So it can also be known as pressure support. We've already talked about this a little bit, but setting up the ventilator, things you need to think about are your FiO2. So what amount of oxygen do you require for this patient? Tempting as it is to put the patient always on 100%, remember that giving too much oxygen is not good for the patient, so try and titrate as soon as you can. We're often guided by blood gases and where we can look at the PaO2, but you can also do this on oxygen saturations, and we're finding at the minute with the ongoing pandemic that we're often going by oxygen saturations for patients rather than repeated blood gases. It's important to let whoever's looking after the ventilator know what you're sort of looking to achieve with your ventilation. So it's always a good idea to say we're aiming for example, a PaO2 of greater than 8 kilopascals or saturations of greater than 88%. And you can titrate this depending on why the patient's ventilated and their background and sort of what you're hoping to achieve. So in ARDS you might have different settings. You then choose your mode, whether it's going to be pressure or volume controlled, or one of the other fancier models that are available. And you can also choose whether this is going to be mandated breaths, so the machine will effectively deliver a set amount of breaths per minute, or whether it's going to allow the patient to join in and trigger some of their own breaths. You can then set your limits, so think about your pressure and your volume. So you don't want to have, for example, maybe a peak pressure of a greater than 30, or you don't want to have tidal volumes, say, greater than 500 mils, or lower than, say, 250 mils. Again, I'm just giving random examples here. You want to choose this based on your particular patient and their demographics and their underlying disease process. You can choose a positive end expiratory pressure. So again, this is a matter of debate as to what we should use. If you're treating a patient with ARDS, so you might want to follow the ARDSnet or ARDSnet guidelines where they titrate the PEEP with the amount of oxygen you're administering to the patient. But just remember to choose a sensible number. If you've got a very high PEEP, you're going to reduce the amount of return to the heart, so venous return of blood to the heart, which will then potentially set up a spiral of a reducing cardiac output and a reduced blood pressure. So often we start at 5, but it is very variable and there is no mandated level, but just titrate that to your patient. Then choose a respiratory rate. I'm going to talk a little bit in a minute about troubleshooting and manipulation of respiratory rate, but think about what you're hoping to achieve with the respiratory rate and then set one appropriate to that. And then thinking about your inspiratory time or your inspiration to expiration ratio. So, but when you change one, you effectively change the other. In health, as I've mentioned, we spend about 1/3 of our time in inspiration and 2/3 in expiration, but in disease states this sometimes has to change. I'm going to talk briefly now about troubleshooting and issues you might run into with ventilation and how you might think about resolving these. So if your patient's got a very high respiratory rate or very high airway resistance, you might find that you actually have to adjust your respiratory rate or your IT ratios to allow the patient time to fully complete their inspiration breath. You can see on the top part of this flow loop, it's not reaching the baseline, so the patient isn't having time to inspire fully before expiration. And you can see at the top right, the IT ratio is set at 1:2, which would be sort of all of us in health. If we weren't being ventilated, that's roughly how we breathe. So if you see the bottom part of the graph, the IT ratio has been changed to 1:1, so inspiratory time and expiratory time are equal, and that the patient is having time to complete their inspiratory breath before they start exhaling. Conversely, if you allow the patient insufficient time to breathe out, you can then cause gas trapping. So your insufficient expiratory time might be due to an increased airway resistance, or it can be iatrogenic. So if you've changed your respiratory rate and changed the IE ratio, you might have accidentally allowed a abnormal amount of expiratory time, or one that's not going to work for that patient. So you can see in the top graph, you have an inspiratory time to expiratory time set as 2 to 1. And you can see at the bottom part of the flow loop that the exhalation is not reaching the baseline. So with every breath, there's a little bit of gas trapping. So this then leads to an increased intrathoracic pressure, reducing your venous return and therefore your cardiac output. And if this continues, you put the patient at risk of a cardiac arrest. So for this, to improve this, you can reduce the respiratory rate, or you can review your I to E ratios. So you can see that this has been changed back to a 1-to-1 ratio in the bottom part of the graph. So this patient now has time to complete their expiration before the next breath in. Sometimes this can happen, particularly with asthmatic patients who are very difficult to ventilate if they are having a severe or life-threatening attack. And sometimes they need to be manually disconnected from the ventilator and effectively decompressed with someone putting pressure on their chest to help remove the trapped gas. If you're having problems with hypoxia, you can first of all think about increasing the fraction of oxygen that you're supplying to the patient. You can think about increasing their positive end expiratory pressure or peak airway pressure and increasing their tidal volumes. Or you can adjust the time that the patient spends in inspiration, and you can do this by manipulating the I to E ratios. Hopefully on the screen you're able to see this, they're quite small, but you can see at the top part we have an I to E ratio of 1 to 2, and then there is a redundant time in expiration. So they've manipulated the settings to having inspiratory time of 2 to 1 for expiration, and you can see there that the square wave of the pressure waveform is prolonged. So they have prolonged time in inspiration, and it's been adjusted so that they spend the minimum time required to complete expiration. So for that loop to get back to the baseline, and the inspiratory breath starts again. If you're having problems with your carbon dioxide, either being too high or too low, think about changing your minute volume, your respiratory rate or tidal volume to manipulate this. But in some situations, you might actually have to accept a higher PCO2. And sometimes, for example, in ARDS, we might accept a slightly higher PCO2, provided it doesn't adversely affect the patient's pH too much. So again, I hope you can see on these graphs, they are quite small. In the first one on the left, you can see that there's quite a lot of redundant time spent in expiration. So this has been changed then in the middle graph, where the respiratory rate has been increased and the minimum time required to complete expiration has been, the time has been manipulated to allow only the minimum time allowed. And then you can further increase the respiratory rate. So you've moved then from an I to E ratio in the left of 1 to 2 to 1 to 1 on the right. After this, once you've increased the respiratory rate and allowed the minimum time for expiration, then you're a little bit stuck, and if you make further changes, you do run the risk of gas trapping and actually making things a little bit worse. So it's important to accept that you can't always make things perfect. You can do the best you can, but sometimes the underlying pathology won't allow you to completely manipulate the numbers to what you want. I'm going to mention a little bit about complications associated with mechanical ventilation. So these can be divided up into direct or indirect, or they can be divided into early or late. There's many different ways, but it's important to think about them. So it's an intervention for a patient which is not without risk of harm. So first of all, when you're actually intubating the patient, there's always the risk that there might be aspiration. You might fail to intubate the patient, you might have an esophageal intubation, or you might have a period of hypoxia. This is something you need to plan for before your intubation, so you should have your plan A, B, C and D of what you're going to do if you can't intubate the patient on your first attempt, who's going to have a second attempt, things that you can do to improve the positioning of your patient, or any additional kit that you might want. And alongside that, there's also the risk of damage to the patient's teeth, lips, larynx or esophagus. And particularly in children, there's a multiple attempts at intubation can lead to edema within the airway, and you can make future attempts difficult. Intubation on critical care is often much more challenging than intubation in theatre. So in theatre you're often choosing a patient electively for a procedure. You're in a place with all the equipment immediately available and with skilled help available. On intensive care, often intubation can be a little bit more frantic because it can often have to be done in a hurry, and it can potentially be just a little bit more chaotic than it is within the theatre environment. So it's important to take a second, make sure you have all the equipment that you need available, that you have the staff that you need available, and that you've commented on your plan and everyone in the team knows what the plan is. Particularly at the minute when we're all wearing PPE, it's so difficult to communicate with each other, and this is where kind of mistakes can happen, or you can set off a chain of adverse events. So it's important to just think about what you're doing, why you're doing it, and who's helping you to do it. Other direct complications secondary to airway for ventilation include sinusitis. Looking a little bit further down the line, if the patient isn't going to extubate easily or needs a prolonged wean, you might be thinking about a tracheostomy, and a tracheostomy itself comes with associated complications. I'm not going to go into that on this talk, but we can have another talk about tracheostomies at another point if you think it would be useful. Prolonged intubation can lead to loss of normal airway function, and it can lead to impairment of patient speech. Other direct complications include increased intrathoracic pressure with positive pressure ventilation, reducing the venous return and reducing the blood pressure. So sometimes you then require vasopressors or inotropes to maintain the patient's cardiac output. The respiratory complications can include barotrauma and volutrauma. So again, important to think about the volumes and the pressures that you're ventilating the patient with. It can also cause atelectasis. There's a risk of ventilator-associated pneumonia, and there's also a risk of oxygen toxicity. It's very easy to leave the patient, start the patient on 100% and forget to turn it down. Neurological complications can include raised intracranial pressure and then the consequences of having either hyper or hypocapnia. Renal complications include increased production of ADH and ANP. And then it's important to think holistically about the indirect complications associated with being mechanically ventilated. Patients can get pressure sores, so think about where your endotracheal tube is positioned. If you're using a nasal tube or if you're using an oral tube, think about the pressure it's putting on the nose or the lips. And then aside from just the tube in itself, think about the patient. If they're on a ventilator and sedated or possibly have some muscle relaxant, you need to think about repositioning the patient, rolling the patient, watching out for pressure points and cushioning those where possible. Think about stress ulceration and consider gastric protection. There's a risk going slightly alongside pressure sores, but a risk of venous thromboembolism. So patients on ventilators, or indeed on critical care in general, should have a daily review for thromboprophylaxis as to whether they need to have something prescribed prophylactically, and if so, what dosing. The risk of muscle atrophy, and the longer you spend on a ventilator, the longer you have to muscle waste effectively. So you need to think about how easy it's going to be to wean the patient and about the risk of atrophy, particularly to their diaphragm. Critically ill patients are at risk of critical illness neuropathy, and one of the risk factors for this is potentially being on a muscle relaxant. So think about, does the patient need to be paralysed? And if they don't, make sure you've stopped that. And if they do, think about this on every review of the patient. Can we reduce it? Do they still need it? Delirium is a really big risk in critical illness. So think about having sedation holds as much as possible. Orientate the patient. So even just someone telling the patient, you are on critical care, today is whatever day it is, whatever time, my name is, and I'm looking after you, this is what's happened, to orientate the patient is really helpful. And you should be screening for delirium every day on your ward rounds. Ventilation can lead to altered sleep-wake cycles, so it's important to be cautious with excessive noise and light, particularly overnight. So we try and offer patients eye masks to help with their sleep and try to minimise the amount of noise and just general chatter and things being restocked and whatnot overnight. Obviously, critical care is busy, particularly at the minute, and you can't avoid that patients will need to be admitted. There will be procedures that have to happen. There is a lot of noise and light on critical care, but where possible, do try and create sort of day and night time for the patient as much as possible. Then thinking about your nutrition. So when they're ventilated, they're not able to use their oral route as normal. So you may be feeding them via an NG or an NJ, or possibly with TPN. So the consequences of that, both for the means of delivering the feeding, has complications, but also the complications associated with not using their GI tract as normal. And post-traumatic stress can be a real problem with patients who survive critical illness. So it's important to be mindful of this and screen for it. And it's not always possible, but patients who have been on critical care, sometimes being able to talk about it afterwards with someone who has been looking after them can be helpful. I'm going to just briefly mention weaning because we're sort of running a little bit over time. Weaning is the process of reducing ventilatory support where the patient is breathing spontaneously and it leads to them being extubated. So weaning is something that's individual for each patient, and you need to think about how you're going to increase your chances of success, because extubating a patient and reintubating the patient is associated with an increased risk of mortality and morbidity. So first of all, why was the patient intubated and has the underlying illness resolved? Is the patient optimised? Have they got an adequate drive to breathe? So have you reviewed their medications and removed any unnecessary sedatives? Have you checked the blood gases to see that they're actually managing adequate ventilation? Have they got the strength to breathe without the assistance of a ventilator? So again, make sure if they've had any muscle relaxant, that has had sufficient time to be metabolised and removed. Are their electrolytes optimal? So thinking particularly about calcium, phosphate, magnesium and potassium. If these are suboptimal, you're going to struggle. And has the patient got critical illness neuropathy? And if so, is that going to impair their ability to be extubated? Think about the respiratory load. Have they got copious secretions? Have they got pleural effusions or pneumothoraces? Or, for example, are they constipated or have any other reason for a distended abdomen, which is going to impair their respiratory mechanics? Then think about your potential airway difficulties. Was this patient a difficult intubation to begin with? Did they require a wake fibre optic intubation, for example? Would it be worth putting down an airway exchange catheter, which would mean if they had to go back off to sleep quickly, that you're able to do that without potentially further airway difficulties? Have they had airway swelling or edema? Are you anticipating this when you extubate them? It's always worth having an airway plan in case reintubation is required. So if a patient was difficult, have you got extra kit available? Have you got someone who's capable of reintubating the patient? And then think about their breathing. And you can think about doing a spontaneous breathing trial, which I'm going to show you a slide for in a moment. So this is just another summary that is from one of the articles in the British Journal of Anaesthesia Educational Supplement, which is worth having a look at. This, again, it's a little bit like the similar slide, but looks at variables which will indicate whether your patient is ready to wean or not. So again, has the reason for intubation resolved? Do they have intact airway reflexes? Are they cardiovascularly stable? Are they awake and responsive? What's their GI function like? Have they got any other issues such as pyrexia? And as well as electrolytes, have you thought about their haemoglobin? So here again this is from one of the e-learning for health modules on ventilation. So there's a couple of really useful modules. If you can access those, it is free. This is one of the tables taken directly from here. And this looks at whether they have sufficient ventilatory drive, sufficient muscle strength, and the ventilator mechanics. So having a look at these three headings and the variables within will give you an idea if your patient's likely to wean successfully. Then I've mentioned a spontaneous breathing trial. So there's different ways you can do this. You can put the patient on a T-piece, or you can put them on some CPAP, or some ventilators will allow a tube compensation. So the patient's effectively doing the spontaneous breathing, however they still have their endotracheal tube in place. And again, from the same article, these are some of the criteria they'll use to terminate a spontaneous breathing trial. So if the patient becomes tachypneic, they desaturate, they become tachycardic, hyper or hypotensive, or showing signs that they're just not managing, like agitation, sweating, or rapid shallow breathing, then these are signs that you probably aren't going to successfully extubate this patient. We're running out of time, so I'm just going to touch on a tracheostomy. This is an option for patients who are requiring prolonged ventilation or who might have failed multiple extubation attempts. I'm not going to go into all of the indications, but there are some advantages to giving a patient tracheostomy. You can reduce the amount of sedation they need, which has a myriad of positive effects, particularly if thinking about their blood pressure, their risk of delirium, etc. You can improve their oral care, so they can have better mouth care and improve their oral hygiene. They can have improved communication. It can be more comfortable for the patient, and it can help with their rehab and their physio. However, timing for tracheostomy is still a matter of debate. It's a little bit older now, but the TrackMan study didn't show any benefit to having an early tracheostomy. But it's difficult to make a sweeping statement. It's, again, an individualised process for that patient. And if you're going to put a tracheostomy in, you need to think about whether you can do this percutaneously on your unit, whether the patient needs to go to theatre and have someone from ear, nose and throat surgeon to insert the tracheostomy. And then you need to think about things like management of it. Are the staff going to be trained to manage that? Have you got sufficient plans in case it would get dislodged? And have you got sufficient kit that you have replacements readily available? So that was a whistle-stop tour through some of the basics about mechanical ventilation. As I've mentioned, there are some really good resources out there. So I've not noted them all individually under the e-learning for health, but if you can access this website, looking at the anaesthesia and the intensive care modules, there's loads of resource within that. The CEA-CCP article I've mentioned at the top, it's now, CEA-CCP is now the BJA educational supplement. Most of these articles are available for free online, so it's worth having a look. And also the frca.co.uk site has some nice resources. It's aimed at people sitting the exams, but it's useful for a refresher. So thank you for listening. Hello. I'm going to talk a little bit about blood gas interpretation for the next 15 to 20 minutes. I'm going to talk about the role of the arterial blood gas, how we can interpret this, and then I'm going to talk a little bit more about metabolic disturbances and include within that calculating the anion gap and how that might be useful. So why bother with an arterial blood gas? Well, these are often very quick to take and process, and sometimes the results will come back more quickly than other blood tests. They allow you to assess the patient's oxygenation and ventilation and have a look at their metabolic state. Depending on the analyzer that you're using, you can often get quick results for electrolytes such as potassium, and some machines can give you an estimate of urea and creatinine. You can do a quick check of the patient's blood glucose and their hemoglobin, and you can also check things like carboxyhemoglobin. So for a relatively quick to perform test, you can get a lot of information. So just a little reminder about acid-base balance. Maintaining a normal pH is essential for your cells to function optimally, and they exist in a state of dynamic equilibrium as demonstrated in the equation below. And just a little reminder that your pH represents the negative log to the base 10 of hydrogen ion concentration, and so you can see that between sort of pH of 6.9 and 7.6 you have a fairly big change in your hydrogen ion concentration, so 125 millimoles per litre at a pH of 6.9, and then just falling to 25 millimoles per litre with a pH of 7.6. So a few top tips for when you're interpreting your blood gas results. First of all, check that you've got the right patient's details, particularly in an acute situation. Often someone might take the gas and somebody else will take it to be analysed. Make sure that it's always clear which patient the sample is from. Make sure that you note the fraction of inspired oxygen that the patient is on. Your machine may prompt you to enter this before it will print out our results, but if not, make sure you always write it down next to the results. Equally, you often need to input the temperature into the gas analyzer before it will process the result. This allows it to make corrections for the gas results according to the patient's temperature. If you're doing a peripheral stab, particularly in an arrest situation or a peri-arrest situation, be sure that you've definitely got an arterial sample. If the results really don't match what you're expecting, you might want to repeat the sample. And then it's really important to make sure you're always correlating your result with the clinical picture. So think about the patient, their fluid balance, and any medications that they're on that could be impacting upon it. There are many different ways you can review your blood gas results. It doesn't really matter if you follow mine or if you have your own system, but what I would recommend is that you make sure you get into a system so that you're looking at every aspect of the gas and making sure you're not ignoring certain parts of it. So it's very easy to look at the respiratory portion and miss the fact that the patient's glucose might have dropped to 1. So whichever system you use is fine, but just make sure that you cover every bit. So I always look at the oxygenation initially, and your appropriate PaO2 will depend on the FiO2 that the patient is currently receiving. Again, just make sure that your sample is actually arterial, or you may get some strange results, and always interpret them based on the FiO2. Next, you can look at the pH. So as you know, the normal range is 7.35 to 7.45, and a pH of less than 7.35 represents an acidosis, where there is an increased serum hydrogen ion concentration leading to acidemia. And conversely, a pH of greater than 7.45 represents an alkalosis, an abnormal process that reduces the serum hydrogen ion concentration leading to alkalemia. Beware that sometimes you can get a pH within the normal range, but this may be due to some compensation from either the metabolic or the respiratory component. So you have to review all values. It's not enough to say, oh, this pH is 7.4, that's fine, and move on. Looking then at the respiratory component, so each lab will have a slightly different variance on what a normal value is. We usually work with a PCO2 of 4.6 to 6 kilopascals being within the normal range. If your PCO2 is less than this, this might be due to a primary respiratory alkalosis, or it could be a compensation for a metabolic acidosis. And then if it's greater than 6, it may represent a primary respiratory acidosis, or it might be due to respiratory compensation for a metabolic alkalosis. This is a really busy slide, so I'm not going to read every little bit out, but it's just demonstrating some causes of respiratory acidosis and potentially whether these are acute or chronic. So it can, you need to think about things like the central respiratory drive, whether that's depressed, whether the patient has any neuromuscular issues, whether there's any factors within the airways, chest wall, pleura or parenchyma, or thinking slightly more broadly, is the patient in shock? Are they septic? Have they had CO2 insufflation into the body, for example, during a laparoscopic procedure? Then also thinking about chronic causes, again, central depression of the respiratory drive, and muscular chest wall, pleural and parenchymal or airway causes. Again, this is another busy slide which I won't read out, but you can review in your own time. But this is some potential reasons for a respiratory alkalosis. And again, you can think of these as whether they might be centrally mediated, whether they're due to hypoxia, whether it's due to something within the lung parenchyma, or whether there's an extrinsic cause. So moving on then from respiratory issues to looking at the metabolic component of the blood gas. So we're looking at the bicarbonate, and the normal range is 22 to 26 millimoles per litre. Again, some labs may have a slightly different variance on this, but this is generally the accepted value. If your bicarbonate is less than 22, then this may be a primary metabolic acidosis or compensation for respiratory alkalosis. If it's above the normal range, so greater than 26, then it may be a primary metabolic alkalosis or compensation for respiratory acidosis. So for a metabolic acidosis, this means there's an increased amount of non-volatile acids within the blood and a reduced plasma bicarbonate. The potential consequences of having a metabolic acidosis include increased catecholamine release, which may lead to tachycardia or arrhythmias, and venoconstriction. So venoconstriction will then increase your venous return, and that runs the risk of causing pulmonary congestion and increasing your pulmonary artery pressures. You may get reduced cardiac contractility, and this may be an impaired response due to circulating catecholamines. However, if it's a very severe acidosis, it may cause myocardial depression. You can also get systemic vasodilatation and cerebral edema. So moving on to talk briefly about the anion gap. This is the difference between measured anions and cations in plasma. Plasma is electrochemically neutral, so any difference in measured anions and cations is due to unmeasured ions. So this can be helpful to establish if you have a metabolic acidosis due to either an excess of unmeasured ions, which is a high anion gap acidosis, or whether it's due to a loss of bicarbonate from the extracellular fluid, which would give you a normal anion gap acidosis. You can calculate the anion gap by adding the sodium and potassium and subtracting the chloride and bicarbonate. There are normally more measurable cations than anions in plasma, and therefore your normal anion gap is usually less than 12 millimoles per litre. It's important to note that when you're doing gases in critically ill patients, their albumin is often low, and albumin is the most abundant unmeasured anion in plasma. So if you don't account for a low albumin in your patient, you can end up showing a high anion gap acidosis as a normal anion gap acidosis. For every gram per litre below 40, your albumin will reduce the anion gap by 0.25 millimoles. So I've just popped the equation in for the albumin-corrected anion gap. If you discover you have a high anion gap acidosis, you need to consider why. It may be due to an excess production of acid, reduced elimination of acid, impaired lactate clearance, or cell lysis. And a popular mnemonic for trying to remember causes that's often used in exams is CAT mud piles. So C, cyanide or carbon monoxide, A, alcoholic ketoacidosis, T, use of toluene, M, methanol or metformin, U, uremia, D, diabetic ketoacidosis, P, for paraldehyde or paracetamol, I, for iron or isoniazid, L, for lactate, E, for ethanol and ethylene glycol, and S, for salicylates. There's also a delta ratio which can be used to help determine if you have solely got a high anion gap metabolic acidosis or whether your metabolic acidosis is of a mixed etiology. There is a caveat to using this ratio in that it assumes that your extracellular bicarbonate is the only buffer for acids, and therefore any change in your anion gap should lead to an equivalent bicarbonate change. So the equation is using the anion gap minus 12 divided by 24 minus the actual bicarbonate, and so that's the ratio. And I'll show you on the next slide that the number you get will determine whether it's likely to be a normal anion gap metabolic acidosis, a mixed high and normal anion gap acidosis, or a purely high anion gap acidosis. If you get a number greater than 2, it usually represents a high anion gap acidosis with pre-existing metabolic alkalosis, or a high bicarbonate before you started having your metabolic acidosis. Calculating the osmolar gap can be useful if you suspect that your patient may have ingested alcohols. In the early stages, your anion gap and your pH may be normal, but over time it gets metabolized into acids, which is then buffered by bicarbonate. So you then get an increased anion gap, but a reduced osmolar gap. So your osmolar gap is your measured osmolality minus your calculated osmolarity. Serum osmolality measures the solute concentration in the serum, and this isn't related to the particle size of the solute. Particles which increase the osmolar gap need to be present in the serum in significant quantities, and having an osmolar gap of 10 or more is considered to be a high osmolar gap. You can also have a normal anion gap acidosis, and for this you should consider whether you have bicarbonate loss, reduced urinary acidification, or possibly excess administration of saline. So the mnemonic for remembering these causes is much shorter, and it can be simply recalled as CAGE. So thinking about chloride excess, presence of acetazolamide or Addison's disease, GI losses, or extrarenal tubular acidosis. Calculating the urinary anion gap can also be helpful. So urine should also maintain electrochemical neutrality, and if you calculate the urinary anion gap, you can help determine whether you have a normal anion gap acidosis or a hyperchloremic acidosis due to renal or GI causes. So if you have bicarbonate loss via the bowel, you should get increased renal excretion of ammonia and chloride into the urine. That means that you get a net loss of hydrogen ions, leading to a negative urinary anion gap due to high chloride excretion. If you have renal disease, for example renal tubular acidosis, impairing acidification of the urine in the kidney, you get less renal tubular excretion of chloride in response to an acidosis, which leads to a positive urinary anion gap. So you can calculate this by adding up your sodium and potassium and subtracting your chloride. You can't use this reliably if you have polyuria, a urinary pH greater than 6.5, or other urinary anions which are being excreted with ammonia, for example keto acids. Moving on then to look at metabolic alkalosis. If your bicarbonate is above 26 millimoles per litre, it's usually rapidly excreted by the kidneys, so you need to have a significant impairment to maintain a persistent metabolic alkalosis. However, this is one of the more common acid-base disorders in critical care. You can use urinary chloride to help diagnose the underlying cause. If this is less than 20 millimoles per litre, it suggests an alkalosis which may respond to chloride administration, and the underlying cause may be due to GI losses. However, if your urinary chloride is greater than 40, it suggests an inappropriate renal excretion of chloride, and this may be due to a mineralocorticoid excess or severe hypokalemia. So this is another busy slide, but it just demonstrates some of the major causes of metabolic alkalosis and gives you a bit of a framework to think about why your patient may be in this metabolic disturbance. So this is a list of references and useful resources. Again, the e-learning for health online modules in anaesthesia and intensive care are really useful, and that's where I've got some of the diagrams from and the little summaries of the equations. And Up to Date is also a really useful resource which might be helpful if you want to look at a specific condition or if you just want to read a little bit more about ABG interpretation. Thank you.
Hi, my name's Caitlin. I'm a core anaesthetic trainee at the Queen Elizabeth Hospital in Gateshead, and I'm going to do a short presentation on the use of IV fluids in critical care. Some of the objectives for this talk are going to include the indications for IV fluid therapy, how we compare common IV fluids, which fluid we use and when, and how we assess the volume and the fluid status of critically unwell patients. The use of fluids in the treatment of patients with critical illness has been ongoing for over 100 years. However, newer evidence is emerging that the type of fluid and the volume of fluid that we use may have negative impact on our patients. The type and volume of fluid that we use will be determined mainly by the indication. And during this presentation, I'm going to focus mainly on resuscitation fluids, which is probably the most commonly used type of fluid in the critical care department. IV fluids are split largely into two categories, colloids and crystalloids. Colloids contain large, insoluble macromolecules, and that ranges from human albumin proteins to synthetically produced starches. In contrast, crystalloids are aqueous solutions with salts dissolved to form ions that pass through the semi-permeable membrane by osmosis. More recently, solutions have been subcategorized into balanced and unbalanced fluids. Balanced fluids are determined by the concentration of chloride within the solution and more closely represent the ionic makeup of plasma. This slide shows a list of some of the more commonly used colloids. In the UK, albumin is almost exclusively used, with other colloids falling out of favour due to increased cost, perceived increased allergic reactions, and a non-superiority to crystalloid. By far the most commonly used resuscitation fluid is isotonic crystalloids, mainly 0.9% normal saline and Hartmann solution. Hypertonic and hypotonic solutions do exist and have specific roles which we'll discuss later. This table compares the ionic composition of commonly encountered crystalloid solutions and compares them to the composition of human plasma. As you can see from this table, balanced solutions such as Hartmann's are significantly more physiological. This is with a significantly lower concentration of both sodium and chloride and with the addition of potassium. By definition, balanced solutions have a chloride concentration of less than 154 millimoles per litre. This is important to remember when we go on to consider some of the negative consequences of high volume, unbalanced infusions. The aim of resuscitation fluids is to increase the volume in the intravascular space, and when choosing a fluid we must consider how it will move through the body water compartments. Colloid molecules are too big to transverse gap junctions, and in theory they will retain water in the plasma space longer than crystalloids. However, in critically unwell patients, the vascular endothelium is leaky and allows colloid molecules to pass into the interstitium, where they there exert an osmotic pressure effect. In contrast, isotonic crystalloid solutions exert their effect through tonicity. They increase the solute concentration in the vasculature and promote the movement of water from the interstitial fluid into the intravascular space. They then equilibrate slowly in the same distribution as normal plasma, with around 20% remaining in the intravascular space. This is why isotonic fluids are more effective than hypotonic fluids. There is ongoing debate and study as to whether colloids or crystalloids are the superior resuscitation fluid, and there remains little consensus between the groups. A 2018 Cochrane review looked at over 65 randomised controlled trials and was unable to draw any significant conclusions. Crystalloid remains the most commonly used resuscitation fluid based on its availability and lower cost. However, there's been no significant changes in mortality demonstrated between the two. Although there is no consensus to a benefit between colloids and crystalloids, new evidence has shown an advantage to balanced fluid resuscitation, particularly when given in high volumes. This is due to the high chloride content of unbalanced fluids such as normal saline. This causes the development of hyperchloremic acidosis due to an intracellular movement of bicarb, reducing the ability of the body to buffer. This results in renal vasoconstriction, a higher incidence of AKI, and worsening outcomes in sepsis. Balanced fluids have also shown a decrease for the need of renal dialysis and an overall reduction in days spent in critical care. In addition, it is safe in renal patients and in hyperkalemia, despite additional potassium. Although the evidence base suggests that there is no superior fluid between colloids and isotonic crystalloids in fluid resuscitation, there are specific circumstances where a specific fluid may be better. This includes the use of albumin in patients with chronic liver disease, or the use of normal saline in resuscitation in patients with gastric losses, where replacement of sodium and chloride would be helpful. We may also want to use normal saline and avoid lactate-containing compounds in the resuscitation of patients with liver failure due to their inability to metabolize lactate. And finally, the use of hypertonic saline, such as 1.8% or 3% saline, can be used in the treatment of both hypernatremia, where large volume replacement is to be avoided, and in cerebral edema, where hypertonicity helps to move fluid from the interstitial spaces and back into the intravascular space. Now we're going to talk about some of the unwanted side effects associated with IV fluid therapy, primarily hypervolemia. There have been multiple studies which have shown the negative effects of hypervolemia, including increased rates of respiratory failure and mechanical ventilation, and increase in rates of sepsis. Patients with AKI and hypervolemia have a higher 30 and 60-day mortality, and in patients with sepsis and hypervolemia, mortality is also higher. Conservative fluid management has been shown to reduce the amount of time patients spend on intensive care. The significant impact of hypervolemia is in part due to the many systems that it impacts, as well as the commonly encountered cardiac, respiratory, and renal failure. Hypervolemia can cause impaired cognition and delirium, malabsorption and ileus, poor wound healing, infections, and pressure ulcers. To avoid hypervolemia, it's important to determine whether our patient will benefit from IV fluid therapy, as only around 50% of patients on critical care will be fluid responsive. The term fluid responsiveness is determined by the increase in cardiac output seen with every fluid challenge, and is determined by where the patient lies on the Frank-Starling curve. Unfortunately, there is no easy way to determine where our patient lies on the Frank-Starling curve, and certainly no parameter that we can use in isolation. Every assessment should start with a clinical assessment of your patient using the A-to-E approach, looking for signs of fluid overload. This may be crackles on the chest or decreased air entry, a raised JVP, or peripheral edema. This should be considered with the patient's fluid balance, both a daily fluid balance, including insensible losses, and a cumulative balance, which should occur over a number of days. In addition, there are a number of investigations which can be used with our clinical findings to help us make a decision. One easy way of determining fluid responsiveness is through a passive leg raise. The advantages of this are that it's easy to perform, it's non-invasive, and doesn't require any specialist equipment. It relies on the autotransfusion of around 500 ml from the lower extremities, and an effect can be seen within 60 seconds. An increase in cardiac output or systolic blood pressure of around 10% would suggest an element of fluid responsiveness, and it can be repeated multiple times until no improvement is seen. Another parameter used to determine fluid responsiveness is the pulse pressure variation, which quantifies the changes in arterial pulse pressure seen during mechanical ventilation. During positive pressure ventilation, inspiration compresses the vena cava, reduces preload, and reduces cardiac output. A pulse pressure variation of more than 10 to 15% suggests an element of fluid responsiveness. It is relatively easy to do with an arterial line in situ and can be used in conjunction with the passive leg raise. It must be noted that a number of strict criteria must be applied before using the parameter, including mechanical ventilation with no spontaneous breaths, tidal volumes of 8 to 10 milligrams per kilogram, no cardiac arrhythmias or open abdomens, and no high PEEP. CVP monitoring is a common way of assessing fluid responsiveness in critical care and has been used by over 90% of intensivists. It measures the hydrostatic pressure in the intrathoracic vena cava and can be easily obtained from a central line. The CVP approximates right atrial pressure and therefore right ventricular end diastolic volume. Its normal value is around 8, with lower pressures suggesting fluid responsiveness. Unfortunately, some evidence around CVP and fluid status is lacking, with several studies done on standing horses. In addition, its accuracy as a marker of left ventricular preload is questionable, particularly in the critically unwell patients, with disrupted venous tone, ventricular compliance, and intrathoracic pressures. The use of ultrasound techniques in the critical care department are also increasing, and the use of echo to assess filling and stroke volume can be used. An ultrasound of the lungs can show the presence of B-lines and pulmonary edema, and the use of a phased array probe below the xiphoid process can show IVC diameter variability between expiration and inspiration. A high variability suggests fluid responsiveness, although its evidence is lacking. When available, an esophageal Doppler may be useful. It measures blood flow in the descending aorta via a probe in the esophagus, using the change in frequency observed when ultrasound waves are reflected off moving red blood cells. It produces a waveform such as the one on the slide and can give a value of cardiac output, stroke volume, flow time, and peak velocity. A low or falling stroke volume or flow time suggests a degree of fluid responsiveness. It is a dynamic measurement and the effect of a fluid bolus can be observed. It's technically non-invasive, although is difficult to do in the awake patient and can't be used in anyone with upper GI pathologies. Other adverse outcomes that occur as a result of high volume IV fluid therapy includes hypothermia from unheated fluids and dilutional coagulopathies, which occur when over 40% of the intravascular volume has been replaced. Thank you for your time. I hope that it's been useful. I have left some references that I found helpful on the following page, as well as a brief summary of some of the more important trials which have looked into the use of fluids in intensive care. Thank you.
Hello, my name is Dr. Sarah Scott and I am a trainee anaesthetic and intensive care doctor currently working in the Queen Elizabeth Hospital in Gateshead in the United Kingdom. I'm going to talk about blood transfusion, and in the talk I'm going to discuss the products that can be used, including packed red cells, platelets, fresh frozen plasma, cryoprecipitate, and some special blood components. I'm going to talk a little bit about transfusion in major hemorrhage, and then a bit about hazards of blood transfusion. And then at the end I'm going to discuss a few papers which are quite useful for the evidence base for transfusion for critically ill patients. The first product I'm going to talk about are red blood cells. These are the most requested transfusion product worldwide. In 2015 it was estimated that 85 million units per year are transfused worldwide. They are prepared from whole blood by removing the plasma fraction after centrifugation and then are preserved within solution. There's many different kinds of storage solution that can be used, but the SAGM solution is the most commonly used one within the United Kingdom. And this consists of sodium chloride and mannitol, which provides the aqueous medium at the correct pH and osmolality for the cells, glucose to provide an energy source for the metabolic requirements, and adenine to maintain the ATP levels. After donation, these can be stored for up to 35 days between 2 and 6 degrees. However, the cells then undergo gradual deterioration. There is a drop in the 2,3-diphosphoglyceride levels, which leads to a left shift of the oxygen dissociation curve. The membrane integrity deteriorates, leading to a leak of potassium and a buildup of lactate, and some of the cells will die and hemolyse. It's estimated that 1 unit of packed red cells will increase the hemoglobin by 10 grams per litre. This is just a slide to mention the different types of blood groups when you're considering which donors will be suitable for which recipients. So we have blood group A, B, AB and O, and the group is determined by the antigens present on the cell. You'll see that there's also antibodies present, and group O is the universal donor because of their lack of antigens. However, they can only receive blood products from group O donors because of the presence of anti-A and anti-B antibodies. Conversely, group AB is the universal recipient, as they do not contain any antibodies. However, due to the presence of A and B antigens, they can only donate to other AB recipients. So we talk about transfusion targets and thresholds. Currently, we're using restrictive thresholds for our red blood cell transfusions. So that would be patients who need to have red blood cells but who are not actively bleeding and do not have a history of acute coronary syndrome, or are not also receiving regular transfusions for other reasons such as chronic anemia. So our threshold for transfusion would be 70 grams per litre for haemoglobin. And then when we're transfusing, we're aiming for a target of haemoglobin of 70 to 90 after transfusion. For patients who do have acute coronary syndrome, we have a slightly higher threshold of 80 grams per litre, and then we'll aim for 80 to 100 grams per litre after transfusion. Some patients will require regular blood transfusions and for things like chronic anemia, and we recommend that they have an individualised threshold set. When transfusing patients, it's important to think about the correct dose. Currently, we're recommending that you start with a single unit red cell transfusion for adults and reassess after each unit. If you're transfusing children or low body weight adults who aren't actively bleeding, then you can use an equivalent volume but calculated based on their body weight. Certain patients will require irradiated blood products, and there's a long list of these, but I've just picked out a few to mention. So patients who are having a donation from a first or second degree relative, patients who have Hodgkin's lymphoma, patients on particular medications such as purine analogues or monoclonal antibodies, any neonates if they've had an intrauterine transfusion, or indeed any intrauterine transfusions, patients with aplastic anemia who are being immunosuppressed with anti-thymocyte globulin, patients who are having allogenic bone marrow transplant, autologous stem cell transplants, and those with known or suspected T-cell deficiency. Platelet donations can either come from pooled Buffy-Cook-derived platelets from 4 whole blood donations, and these are suspended in an additive solution and plasma from one male donor, or it can be an adult therapeutic dose obtained from a single donor by apheresis donation. Platelets should be stored at 22 degrees, and they need to undergo gentle agitation in an approved incubator. They mustn't be placed in the refrigerator. After they're removed from the storage incubator, transfusions should begin within 30 minutes. Each pack will contain 250 to 350 ml, with a platelet count in the pack of greater than 2.4 per adult dose, and the transfusion should increase the patient's platelet count by around 30. They do not have to be the same blood group as the patient. However, D-negative children and women of childbearing potential should receive D-negative platelets because of the small risk of them developing immune anti-D. If group O platelets are given to non-group O child, they should be selected to be a high titer negative. The risk of transmission of bacterial infection is higher than with other blood components, and this is because of the temperature the platelets are stored at. However, the risk of transmission of bacterial disease is reduced by screening before they're released. When considering transfusion targets and thresholds for platelets, these should be stratified depending on whether the patient is currently bleeding or undergoing invasive procedures or surgery. You might consider a prophylactic transfusion of platelets in a patient whose platelet count is less than 10, who is not bleeding or about to undergo an invasive procedure or surgery and doesn't have chronic bone marrow failure, autoimmune thrombocytopenia, heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura. Patients who are having invasive procedures or surgery, you might consider giving them a prophylactic transfusion to raise their platelet count above 50, and you might consider a higher threshold, for example 75, if they have a higher risk of bleeding. But this will depend on the specific procedure the patient's having, the cause of their thrombocytopenia, the trend in their platelet count, so whether it has suddenly fallen over hours to days or whether it's been low for months, and coexisting causes of abnormal hemostasis. You might consider raising the platelet count above 100 if you're having surgery at a critical site. So this might include the posterior fossa in the central nervous system or the posterior segment of the eyes. There are times when prophylactic platelet transfusion is not indicated despite a low platelet count. This includes chronic bone marrow failure and a number of thrombocytopenias. There are also procedures which carry a low risk of bleeding, such as central venous cannulation or bone marrow aspiration and trephine biopsy, and these can be carried out without platelet transfusion. Generally, a single pool of platelets is sufficient for most adults. Moving on to fresh frozen plasma. This is leukodepleted plasma which is rapidly frozen to below -25 degrees, and this maintains the integrity of labile coagulation factors. It can be thawed using either a dry oven, a microwave, or in a water bath, and once thawed it can be used for up to 24 hours, but must be stored at 4 degrees. It should never be refrozen, and once out of the fridge it must be used within 30 minutes. Roughly 300 ml are in each bag of FFP. In the UK it's male-only plasma donation, and this is to reduce the incidence of transfusion-related acute lung injury, and I'll go on to talk a little bit more about this later. Fresh frozen plasma contains all the factors of the soluble coagulation system, and this includes labile factors 5 and 8. The fibrinogen content of 4 units of fresh frozen plasma is roughly 2 grams, and this is compared to 4 grams of fibrinogen in 2 pools of cryoprecipitate. FFP should be the same group as the patient who will receive it. If the patient's blood group is unknown, you can give group AB fresh frozen plasma, as it doesn't contain any anti-A or anti-B. We dose FFP based on patient weight, and we recommend 15 ml per kilogram. Within the UK, patients who've been born in 1996 or later are given FFP sourced from outside of the UK and has undergone viral inactivation, and this is to reduce the transmission of new variant CJD. Indications for transfusion of FFP include to replace clotting factors during major hemorrhage, particularly in trauma or obstetrics, acute disseminated intravascular coagulation with bleeding, actively bleeding patients where their INR is greater than 1.5 or an equivalent point of care testing, immediate reversal of warfarin-induced hemorrhage where prothrombin concentrate is unavailable, thrombocytopenic purpura with plasmapheresis, replacement of coagulation factors if specific factors are not available. It has a limited role in the management of mild or moderate coagulation abnormalities in non-bleeding critically ill patients before invasive procedures, and it's not recommended for use in patients with cirrhosis or liver disease unless they have a significant coagulopathy. It shouldn't be used as routine circulatory volume replacement. Cryoprecipitate. This is a leukodepleted plasma product which contains concentrated factor 8, von Brillavand factor, fibrinogen, factor 13 and fibronectin. It's produced by further processing of fresh frozen plasma and is stored at -25 degrees. Once it's thawed, it can be kept at ambient temperature for 4 hours, but should not be kept in the fridge again. Within the UK, it is mainly available as pooled bags of 5 units with 100 to 200 ml per bag. However, can be given in 1 unit volumes of 20 to 40 ml. Each single unit has 400 to 450 milligrams of fibrinogen, and pools of 5 units will contain at least 2 grams. And an adult dose would be 2 pools. It should be transfused using a standard blood giving set with filter. Indications for cryoprecipitate include hypofibrinogenemia, which could be due to major hemorrhage or massive transfusion. It's increasingly used in major trauma, obstetric hemorrhage, and in cardiac bleeding. During major hemorrhage, you should maintain fibrinogen greater than 1.5 grams per litre, and this should be slightly higher in an active obstetric hemorrhage, where you're aiming for greater than 2 grams per litre of fibrinogen. It can be indicated in combined liver and renal failure with bleeding associated with thrombolytic therapy, disseminated intravascular coagulation with fibrinogen of less than 1 gram per litre, and it can also be indicated in advanced liver disease to maintain fibrinogen of greater than 1 gram per litre. Again, in the UK, for those born after 1996 or later, it's made from FFP sourced from outside the UK, which has been inactivated, which has viral inactivation. For smaller children, it's available in single units, and full units are available for older children and young adults. I'm just going to touch upon special blood components. These include prothrombin complex concentrate, which contains factors 2, 7, 9 and 10, protein C, protein S and heparin. This can be rapidly reconstituted and provides a high concentration of these clotting factors within a small volume. It's indicated in acquired factor deficiencies and for urgent reversal of warfarin. I'm also going to mention recombinant factor 7A, which is licensed for use in haemophiliacs. It is the most potent thrombin generator currently available. However, if it's used late in exsanguinating patients, it has a poor mortality benefit and is often associated with complications. In cardiac surgery, it has been shown to reduce reoperation rates and transfusion in a bleeding patient. However, it may also increase the risk of thrombotic complications, and therefore it should really only be used with specialist haematological advice. I'm now going to touch on transfusion in major hemorrhage. I'm now going to talk about transfusion in major hemorrhage. There are many definitions, but some that I've included are loss of more than 1 blood volume within 24 hours, which is around 70 mils per kilogram, loss of 50% of total blood volume in less than 3 hours, bleeding in excess of 150 mils per minute, and for children, those who require a transfusion of greater than 40 mils per kilogram. And the blood volume in children over a month old is roughly 80 mils per kilo, which is slightly greater than in adults where it's 70 mils per kilogram. A pragmatic and clinically based definition would be bleeding that leads to systolic blood pressure of less than 90 millimeters of mercury or a heart rate of greater than 110 beats per minute. In the next few slides, I'm going to show you part of the major hemorrhage protocol from our major trauma centre at the Royal Victoria Infirmary in Newcastle. At the top, there is a little bit about paediatrics, but I'm really only going to focus on the adult version. So first of all, it's important to recognise major hemorrhage. So in a patient who's bleeding and you suspect it's ongoing, their systolic is below 90 millimeters of mercury. They're not responding to initial fluids, or they've had penetrating trauma, positive fast scan, or they've been pre-alerted before they're brought into the hospital. In a major hemorrhage, it's important to have a lot of help available and for it to be as senior as possible. So if you know you've got a patient coming who's bleeding, try and get some help and some senior help. You need to assess the patient's ABCDE as you would for any critically ill patient. So make sure they're monitored, that they have high flow oxygen administered, so 15 litres via a non-rebreathe mask, and that you've got large bore IV access. If you can't ascertain IV access quickly, think about using intraosseous access. You can then use a rapid infuser if you have one available. You should take samples early for group and save, full blood count, coagulation, and urea and electrolyte. And if you have it available, you could think about monitoring using a HemoQ, arterial blood gases, or ROTEM or TEG. Once you've recognised that major hemorrhage is happening, it's important to let the blood bank know. Within this trust, we would ring the blood bank and tell them that we need to start the active major hemorrhage protocol, but every hospital will be different. So whatever you need to do to alert the blood bank that you're going to be needing a lot of blood, and make sure that you have someone who's able to get it for you. So as part of our protocol, we have a porter who will then be solely devoted to getting blood from the blood bank and bringing it to the patient. So thinking about hemorrhage, whilst giving the blood products is great, you need to turn off the tap and think about stopping the bleeding, as well as replacing what's lost. So if there's anything that you can compress, you can put direct pressure on or put a dressing on. If there's a fracture, we know these can bleed quite extensively, so think about splinting them. And for a distal injury, think about applying a tourniquet if possible. If you have a non-compressible site of bleeding, you need to think about how you're going to stop that, and that might involve going to theatre, or if you have access, using interventional radiology. If you're in obstetric theatre, think about the 4 T's: your tone, tissue, trauma or thrombin, and then think about how you might deal with these. So whether you need to use uterotonic drugs or early transfer to theatre. If you're having a gastrointestinal bleed, you can think about using drugs such as terlipressin. You can think about scooping or IR or surgery. And if you have a patient who's anticoagulated, think about how you're going to reverse that. If you have access to it, cell salvage can be very useful and can reduce the amount of donated blood products that you need to use. However, it cannot solely be used for resuscitating the patient. It's slow to collect, but it can be used to top up what else you're giving the patients. So the next thing to think about is resuscitating and preventing coagulopathy. So we tend to give patients 1 gram of tranexamic acid as a bolus intravenously. And currently we're transfusing in a ratio of 1 unit of red blood cells to 1 of fresh frozen plasma. So the packs that will be given from our blood bank, it will have 4 units of red blood cells and 4 of fresh frozen plasma. And then from the second box onwards, we'll get other products. So we'll get platelets in the second box and then cryoprecipitate in the next box. Everyone's hospital will be different, so it's important to see what's available in your own and in what order the products will come. And we recommend that you continue to repeat samples after each pack, just so that you can get an idea of where you're up to in resuscitation efforts. Although again, this will depend on the hospital you work in and what's available. And sometimes taking bloods, by the time you get the result back, you're too far down the line for those results to be meaningful. If you're going to be giving a massive transfusion, you need to think about other things that you can do to improve the patient's outcome. So blood products are generally cooled. So you need to think about warming your patient, and if you can, warm the products through a warmer before giving them to the patient. Think about the buildup of acidosis. So we mentioned that over time there is a buildup of lactate within the red blood cells. So you can think about measuring blood gases and measuring lactate to keep an eye on this. Be mindful that there will be potassium in the bags, as again we mentioned, the cells degrade over time and will leak potassium. So it can be easy for patients who receive a large transfusion to become hyperkalemic. So just think about keeping an eye on their potassium levels and be ready to give some insulin dextrose if required. Patients can also get hypocalcemic, and the citrate used to store the blood interferes with this, so you can think about replacing their calcium with transfusion. And targets we might use in massive transfusion or major hemorrhage is keep the patient's temperature greater than 36, try and keep their pH greater than 7.2 with a base excess of less than 6 and a lactate of less than 2. Aim for a haemoglobin of greater than 100 during the hemorrhage, and once you've got control of the bleed, try and keep their haemoglobin greater than 80. Aim for platelets of greater than 100 and fibrinogen of greater than 1.5 or greater than 2 if you're in obstetrics. Aim for ionised calcium of greater than 1 and a potassium of less than 5.5. And once you've managed to successfully control the bleed and resuscitate the patient, don't forget to let your blood bank or your blood labs know that you're not going to need any more products. Moving on then to talk about complications of transfusion. I'm not going to dwell on this too much, I've just picked out a few to mention. But these can be roughly divided into early complications and late. So early things to watch out for are hemolytic reactions. So these can be early within seconds or can be delayed. You can have non-hemolytic febrile reactions. Patients can have allergic reactions to the proteins or IgA. You can have transfusion-related lung injury, reactions secondary to bacterial contamination. They can have transfusion-associated circulatory overload. And then you think about things like air embolus, thrombophlebitis, hyperkalemia, citrate toxicity, hypothermia, or clotting abnormalities. Then moving on to later complications, you can have transmission of infection. This can be viral, bacterial, or parasitic. You can have graft versus host disease. You can have iron overload, but this tends to be after chronic transfusions, or immune sensitization. Recognising and managing an acute transfusion reaction. This can be difficult if the patient's anaesthetised. It's going to be difficult for them to tell you if they feel unwell. But things to look out for are tachycardia. They can become hyper or hypotensive. They may develop fever or rigors. There may be pain at the transfusion site. They may have chest or abdominal pain. You may notice hemoglobinuria, or they may start to show signs of DIC. The important thing is that you keep an eye on the patient when they're having a blood transfusion and just think about if their observations change or something unusual happens, just think, could this be a transfusion reaction? And if you're concerned, stop the transfusion, keep the giving set in the blood, don't throw it in the bin, because the lab can use this to check for what may be the cause of the transfusion reaction, and then assess and treat your patient in an A, B, C, D, E, so airway, breathing, circulation, disability, and everything else fashions. Acute hemolytic transfusion reactions are caused by the recipient's antibodies attacking incompatible donor red cells. And this is due to ABO incompatibility, and the leading cause of this is actually human error. So somehow mixing up blood products before you administer them to the patient, or sending the wrong patient's sample to be cross-matched. And we asked for 2 samples taken separately from a patient to go to the blood bank before they will cross-match and issue blood. It's really important when you're taking samples to send to the blood bank that you take them and label them immediately, and you check the details that you're labelling them with the patient. So if they're unconscious, use their wristband, but if they're conscious, get them to confirm and tell you their name, their date of birth, and other unique identifiers. This immunological reaction will destroy the donor red cells and can cause disseminated intravascular coagulation and acute renal failure. Transfusion-related acute lung injury, or TRALI, is usually due to antibodies from the donor which react against the recipient's white cells, and generally in these cases the donor is a Paris woman. Symptoms usually start within 6 hours of transfusion, and it generally shows signs of fluid overload. So this can make it a little bit difficult to identify, because if the patient's had a lot of blood products and a lot of fluid, or has problems with their left ventricle, it can be easily confused for another cause. And often the patient will have shortness of breath or a dry cough. If you do an X-ray, you might see bilateral patchy infiltrates. There is no specific treatment, but they might require admission to intensive care for management of effectively what is like an ARDS type picture. And there's an associated mortality of 20%. Transfusion-associated circulatory overload is the acute left ventricular failure associated with an excessive volume of transfusion. And it can present as left ventricular failure would, with shortness of breath, cough, raised JVP, frothy pink sputum, tachycardia, hypotension, and fine inspiratory crackles and auscultation. Again, this may not be immediately recognised, as the patient may already have an element of left ventricular failure, so it's just important to be mindful if patients have an impaired left ventricle, think about slowing down the transfusion if you can, or covering them with some furosemide as a diuretic. And this is managed with oxygen and diuretics. Delayed hemolytic transfusion reactions. These are less severe than a reaction secondary to ABO incompatibility, and it's due to the immunological consequences of recipient antibodies to lesser red cell antigens of donor cells, so for example rhesus or KIT. The recipient's antibodies will coat the donor cells. These are then gradually removed by the liver and spleen, So this is extravascular hemolysis, and it can lead to the destruction of 400 mils per day of donor red cells. The patient may not show any symptoms for up to 14 days, but they may have fever or chills, falling hemoglobin, and a rising bilirubin. Often they don't actually require any specific treatment, but you may have to retransfuse them if there is a significant level of hemolysis. Transfusion-associated graft versus host disease. This is due to live lymphocytes from the donor which are recognised the recipient as foreign. These proliferate in the recipient and they damage cells which express HLA antigens. So these can be cells in the skin, the GI tract, liver, spleen, and bone marrow. These can develop up to 2 weeks after transfusion, and the patient might present with fairly non-specific symptoms, but things like fever, rash, diarrhea, and hepatitis. And unfortunately, this is usually fatal, and there is no treatment specifically available. It can be prevented by gamma irradiation of blood products, which will destroy surviving white cells. Finally, I'm just going to move on to talk a little bit about critical illness and mention a few trials which might be of interest. So firstly, anemia of critical illness. Many patients admitted to critical care are anemic, and there's many reasons for this. It could be something iatrogenic, such as we have given them fluid resuscitation and hemodiluted them, but always think of things in broad groups. So are they losing red blood cells? Are they bleeding somewhere? Have they got a coagulopathy? Could this be due to liver disease, sepsis, thrombocytopenia? Are they failing to produce adequate amount of red blood cells? Have they got bone marrow suppression due to medication they're taking or due to an inflammatory process? Or do they have functional or absolute erythropoietin deficiency? Are they having increased destruction of red blood cells? And again, this could be due to drugs or toxins. Or have they got a nutritional deficiency, such as iron, folate, or B12, preventing them from making sufficient red blood cells? So I'm going to now talk about 4 papers briefly, which have impacted upon our transfusion targets in critical illness. So the first study I'm going to mention is the TRIC study, and this is quite old now, it's from 1999, and it was a multi-centre randomised controlled clinical trial of transfusion requirements in critical care. It was carried out in Canada, and patients who were admitted to intensive care received either a restrictive or a liberal transfusion strategy to see whether this altered their mortality. So the restrictive strategy, patients had a threshold of less than 70 before they would be transfused, and in the liberal strategy, if their hemoglobin fell below 100, they could be transfused. There was no significant difference in 30-day mortality, but there were significantly lower mortality in restrictive subgroups in the under 55s and those with an Apache 2 score of less than 20. There's then the TRIS study, which is more recent. This is a Scandinavian multi-centre blinded randomised controlled trial, which was looking at whether a lower or higher hemoglobin threshold should be used for patients who had septic shock. And they again were looking to see whether this would impact upon their mortality. So in patients with septic shock, the intervention group weren't transfused unless their hemoglobin fell below 70. In the control group, they would be transfused if their hemoglobin fell below 90. And they found no mortality difference whether they used a restrictive or a liberal transfusion strategy. In 2016, there was the Ironman study looking at intravenous iron or placebo for anemia in intensive care. So as we've already mentioned, anemia is common in critical illness. This was an Australian double-blinded randomised control trial. It only had small patient numbers, 140, and they looked to see whether giving them all IV iron would reduce the need for blood transfusion. So if your hemoglobin was less than 100, you would get an iron transfusion, but there was no significant difference in the median number of units of red blood cells transfused, and patients who were given an iron transfusion did leave hospital with a higher hemoglobin. Then looking back at a paper in the New England Journal of Medicine from 2017, this looked at the age of red blood cells that were used for transfusion, and it was based on the assumption that perhaps patients with critical illness should have fresher cells, so ones which were more recently donated. And this was carried out in a number of sites across the world, so Australia, New Zealand, Ireland, Finland, Saudi Arabia. And the threshold for transfusion was decided by the clinician, but if the clinician decided they needed to transfuse the patient, those in the intervention group had blood that had been stored for a mean duration of 11.8 days. Those in the control group had a longer mean duration of storage, so that was 22 days, and they found no significant difference in 90-day mortality. So this has been quite a long talk. I'm going to summarise with just a couple of key points. For red cells, most patients can tolerate a restrictive threshold of 70 unless they have acute coronary syndrome or are actively bleeding. Use single units and reassess after each one. Platelets, they need a good reason before you transfuse them, so think about whether the patient is actively bleeding or is going to undergo an invasive procedure, otherwise you can often hold off. In critically ill patients, they don't need the freshest blood. Giving them IV iron does not reduce their requirement for transfusion, and maintaining this restrictive threshold of 70 grams per litre is acceptable, including during sepsis. So I've made a list of some of the references and resources I used. The JPAC Transfusion Handbook is available via Google, which is really helpful. The AAGBI guidelines about the use of blood components and alternatives is also available online, and that's where quite a lot of the information has come from. Then there's also some information in the e-learning for health modules, which are free online. Thank you very much for listening.
Hi, my name's Caitlin. I'm a core anaesthetic trainee at the Queen Elizabeth Hospital in Gateshead, and this is a short talk on sedation in critical care. Some of the objectives from this talk will include the aims of sedation, common sedation scoring systems, and the pharmacology, dosing and side effects of the most commonly used sedatives in critical care. It is important to think about why we're sedating our patient. Most commonly, this is to facilitate uncomfortable or often painful treatments, such as endotracheal intubation, mechanical ventilation and cooling. It may also be to control one aspect of the patient's physiology. This could be, for instance, managing CO2 in the neurological trauma patient, or to reduce oxygen consumption in sepsis. Sedation may also be used to treat delirium and to manage patients with difficult behaviours that may be the result of mental illness or drug-induced psychosis. And this may require deep sedation in those who may be a risk to themselves or others. Currently, there is no one universally accepted superior sedation or sedation protocol. There are multiple drugs used in the sedation of patients on critical care, usually in combination, and include IV induction agents such as propofol, benzodiazepines such as midazolam, and opiates. Analgesia is an important part of sedation, and over 90% of patients in critical care experience pain. Emerging evidence also suggests that sedation should be titrated both up and down to a targeted score, and the development of scoring systems has improved sedation throughout critical care. Evidence suggests that there are negative effects of both under and over sedation, and this has led to the development of sedation scoring systems, which aim to provide consistent, goal-directed sedation that is tailored to individual patient needs. Associations with undersedation include higher metabolic demands, immune dysfunction, and PTSD, whilst oversedation is associated with prolonged critical care stays, longer periods of mechanical ventilation, and higher mortality rates, as well as a lower number of people being discharged to their own home. Deep sedation is also associated with the use of neuromuscular blockers, which can increase your risk of critical care neuropathy. One commonly used sedation scoring system is the RASS score, or Richmond Agitation Sedation Scale. It is a subjective clinical assessment which can be done multiple times throughout the day and is based around a 10-point scale that ranges from combative, violent and dangerous to -5, unrousable. The target for most critically unwell patients is between 0 and -2, which would be alert and calm and lightly sedated. The RASS score is quick, easy to replicate, and can be done several times throughout the shift. However, it cannot be used with those having neuromuscular blockade. The RASS score is just one of many sedation scales, and others include the Ramsey, Adam-Brooks and Bloomsbury scales. Some non-subjective ways of measuring sedation include instrumental tools such as the EEG and the bispectral index or BIS monitor. EEGs are rarely used in the critical care setting as they are labour intensive and require specialist skill to interpret. However, BIS monitoring is becoming increasingly used. These have previously been used as depth of anaesthesia monitoring for total intravenous anaesthesia in theatres. It is based around the EEG waves with electrodes placed on a patient's forehead. The BIS monitor then provides a number between 0 and 99. 0 would be no cortical activity, while 99 would be the number expected in a healthy and awake patient. A target BIS number of between 40 and 60 is consistent with general anaesthesia and is a useful way of measuring sedation in those undergoing neuromuscular block, where the risk of awareness could cause significant adverse events. Propofol is a phenolic derivative used as an IV induction agent for anaesthesia. It is very lipid soluble and presents in a lipid emulsion of 1 or 2%. Its high clearance and volume of distribution mean it has a quick onset and offset, which is ideal for titrating. Its side effects include hypotension, and this often requires the use of vasopressors to overcome. One significant side effect to be aware of is propofol infusion syndrome, a rare but dangerous complication which is more commonly seen with severe illness and with the administration of catecholamines and glucocorticosteroids. It is also more common in those with carbohydrate depletion and with severe illness, so is more common in the critical care population. It often presents as a high anion gap metabolic acidosis, rhabdomyolysis, hyperkalemia, AKI, and elevated liver enzymes, and is managed by stopping the propofol infusion and with supportive management. Propofol is an anaesthetic and does not provide any analgesia. Alfentanil is a commonly used opioid in sedation in critical care. It is a mu receptor agonist and runs in an IV infusion in concentrations of 1 mg per ml. It has a stable context-sensitive half-life of around 50 minutes, meaning that it doesn't accumulate and it is useful to use in patients with renal failure. It also has a quick onset and works within 90 seconds. Its lack of histamine production also makes it safe in asthmatics. Alfentanil suppresses the laryngeal reflex, allowing mechanically ventilated patients to have a reduction in other sedation, such as propofol. Like propofol, it causes hypotension and respiratory depression, but it has minimal sedation, so requires additional drugs such as midazolam or propofol. Like all opioids, there is a risk of tolerance and it increases constipation. Alfentanil is hepatically metabolized by the same mechanism as midazolam, so when used in conjunction they can potentiate the effects. Midazolam is one of the more commonly used benzodiazepines for sedation in the intensive care unit. It works via the benzodiazepine receptor to potentiate GABA. It has many effects which make it a good sedative, including an anxiolytic, hypnotic, muscle relaxant, anticonvulsive effects, and the ability to produce anterograde amnesia. It is given as a continuous infusion in a solution of 1 mg per ml and causes hypotension and respiratory depression. It is favoured over some other benzodiazepines such as diazepam due to its fast onset and quick clearance, although of note it does accumulate, especially when used with alfentanil. Two less frequently used sedatives in the intensive care unit are clonidine and dexmedetomidine. They are selective alpha-2 adrenal receptor agonists and act centrally to produce sedation, reduction in anxiety, analgesia, and a reduced sympathetic output. They are mainly used in association with other sedatives like propofol and midazolam. Their particular benefits include an added analgesic effect, a non-sedatory effect, and no cardiac depression. This allows patients to have a reduced vasopressor requirement and reserved muscle tone for spontaneous ventilation. Patients are more easily woken by external stimuli and can cooperate and typically obey simple instructions. Despite this, there has been no reduction in mortality and only a 1-day reduction in length of ITU stay and number of days mechanically ventilated. There is currently no evidence that either drug reduces the incidence of delirium. Its side effects include hypotension and bradycardia, which can be profound, and a rebound hypertension if quickly withdrawn. Dexmedetomidine in particular was developed specifically as a sedatory medication in critical care and requires complex dosing, which is weight-based, in a table provided by the manufacturer. Some patients may have high sedation requirements or difficulty weaning. In these circumstances, it's important to consider why this may be. Some patients may be undergoing alcohol withdrawal and need regular benzodiazepines such as chlordiazepoxide. Other people may be in drug withdrawal and require treatment for this. Smokers may need nicotine patches, and people with coexisting mental illness may need their regular medications prescribed or new ones started to aid with weaning. In addition, it is worth considering non-pharmacological management. This includes good positioning and regular turns and physiotherapy to remove discomfort. Adequate temperature control is important, especially if patients are septic or pyrexial. Good hydration and nutrition remove symptoms related to thirst and hunger, and simple analgesia such as regular paracetamol may be enough. Improving the wake-sleep cycle will also help with sedation and can be facilitated with earplugs, eye masks, and decreasing noise and lights at night. Thank you for your time. I hope you found this presentation useful. Again, I've included some references that I found helpful and a short slide on the summary of evidence. Thank you.
We're running over slightly. We've got about 20 minutes to go. We've got one more presentation on transfers. Just be aware that you can review these anytime on YouTube. We'll provide the link out to the hospital so you can access them anytime you want. But for now, we'll move on to transfer, and do remember to keep those questions coming in.
Hi, my name's Caitlin. I'm a core anaesthetic trainee at the Queen Elizabeth Hospital in Gateshead, and this is going to be a short talk on the transfer of critically unwell patients. So some of the objectives from this presentation will include who we transfer and why, and when and how the best way to do this is, how we optimise our patients before transfer, and some of the physiological implications of transfer, including air travel and altitude, and at the end some tips and tricks about how we can make a smooth transfer. So for some background, here in the UK we do around 9,000 transfers per year, although this number is rising, and we transfer for a number of reasons. First of all, to access specialised care that may not be available in our hospital, and locally that includes neurosurgical care, the transplant team, and also the ECMO teams. We also do inter-hospital transfers of patients from our critical care unit to places such as theatre and the CT scanner. And we repatriate a small number of patients, both locally and even less internationally. There is an indication for transfer due to a lack of resources, and this is most commonly lack of beds and a lack of staff, and this has become more apparent within our region due to the coronavirus pandemic. It's also worth noting that 96% of our transfers in the UK occur overnight, and that 2/3 of these patients are level 3 patients. And these are important considerations when we're thinking about the safety of our transfers and the resources required. So why is transfer training important? Well, first and foremost, transfers are risky. They have a high incidence of adverse events, which can reach as high as 68%, with serious adverse events happening between 2 and 4% of the time. In the majority of cases, this has been due to a lack of familiarity with transfer processes, transfer equipment, and with staff. And this leads on to the second point, that we may not have all the equipment or the help that we would want, or in some cases that we need. And this was again demonstrated by the Faculty of Intensive Care Medicine, who showed that only 50% of units in the UK had dedicated transfer equipment, such as trolleys, and that often equipment isn't universal between departments and certainly between hospitals. It also showed that 88% of trainees in the UK had to transfer patients completely alone. It's also important to familiarise ourselves with transfer processes, because it may be something that we have never done before and are asked to do for the first time overnight by ourselves with critically unwell level 3 patients. And here in the UK, 39% of our trainees had been asked to complete a transfer when they felt they weren't adequately experienced to do so. So before we begin preparing for our transfer, there are some things that we have to do. First of all, we have to ensure that a senior clinician, preferably a consultant, is aware and has approved the transfer, and that is both in our own units and in the receiving hospital. And then to move on to see if the transfer is safe. So we can begin by thinking about whether or not it is necessary and that the risks and the benefits are well balanced. It may be that this is a life-saving procedure, such as neurosurgical intervention, and almost certainly the benefits of transfer will outweigh the risks. However, this may be a more elective transfer and may include a repatriation or for bed pressures, and there may be a more appropriate time or way to transfer the patient. It's also worth considering whether or not a transfer can be avoided altogether if a visiting service can come to you rather than you going to them. The next thing we have to consider is whether or not we can facilitate the transfer, and that means do we have the right equipment to do so, and also enough staff and the right staff mix. It may be that if you've got a junior member of the medical team on their first transfer, that it's more appropriate to have a senior nurse. It's also worth considering if there is a more appropriate patient to move, whether there's a better time, and if there's a more appropriate team, as previous studies have demonstrated better patient outcomes when dedicated transfer teams are used. So the next thing to think about is how we're going to do the transfer. This might be on foot if it is a short inter-hospital transfer, say between the critical care department and theatres or the CT scanner. And the other main options for transfer include by road and by air. And the main determinant for this can often be distance. Most of the transfers within the UK are done by road and by ambulance, due to the relatively small distances that need to be travelled. But it could also be determined by the urgency or by the geography and weather. Inaccessible mountains, for instance, are going to need helicopters, whereas long distances might be more appropriate by plane. It is also worth saying that not all air travel is quicker than road travel, and that travel by air requires specialist teams. They often require a lot of organisational time and are often much more costly. So once we have had our transfer approved by a consultant, we've determined that it's safe and we know how we're going to travel, we can begin preparing our patient for transfer. And that's most easily done using the A to E approach to make sure that nothing is missed. So starting with A, it's important to ask, do we have a secure airway? And if we do, is it securely taped and its length checked and documented? If you don't have a secure airway, it's important to consider if things will deteriorate or are likely to deteriorate en route and therefore should be managed prior to leaving, as intubation or re-intubation in the air or at the side of the road is particularly dangerous. Moving on to breathing, if the patient is mechanically ventilated, make sure that you're happy with their pressures and volumes and you have a recent blood gas. And make sure that you have reliable monitoring in the form of a SATS probe, and if they're mechanically ventilated, CO2 monitoring is mandatory. It's essential to calculate your oxygen consumption and make sure that you have enough plus extra for the duration of your journey, bearing in mind that non-invasive ventilation and high-flow nasal cannulas can have a particularly high oxygen consumption. It's important to ensure extra ventilatory equipment in case of failure and in the case of oxygen failure, in the form of C-circuits, face masks and ambu bags. It's also important to have checked your transfer ventilator to ensure it's passed its safety checks and you're familiar with how it works. So moving on to C, the first thing we should check is, has the patient been adequately fluid resuscitated? Is there any room for us to improve their cardiac output and their hemodynamic stability before we leave on our transfer? The physiological changes that we'll see in transfer, which we'll discuss later, are often exacerbated in patients who are already underfilled. It's also important that if we think the patient is going to require blood products, that we have them with us. Have they been ordered? And in some cases it may be appropriate to have a new group and save request done to speed up the ordering of blood products when you get to your transfer destination. As with all critical care patients, it's important that we have adequate IV access. Usually 2 wide bore IV access is required, and this can include central access if you feel that it may be required. It's important to ensure that the access is going to be reachable for you on your transfer, as you may be strapped into a seat further away, or it may be under blankets, dressings and restraints. It's also important to secure your lines firmly to make sure that they don't come out mid-transfer. Next, we move on to cardiovascular monitoring, and this should include ECG monitoring as a minimum, as well as invasive blood pressure monitoring if required, usually in the form of an arterial line. However, as always, we should have backups, and a non-invasive blood pressure cuff is essential in case of arterial line failure. At this point, it's also worth calculating any vasopressor requirements and ensuring that you've got plenty for the duration of your journey, as well as backups for all of your infusions, and to ensure adequate pumps and pressure bags if required. Moving on to D, if patients are sedated, then ensure an adequate depth, as transfer is one situation where light sedation is often contraindicated and paralysis is often helpful. Depending on the length of your transfer, it may be appropriate just to bolus paralysis, for instance if you're going to CT scan or a transfer to theatre, and this may reduce the number of infusions that you have going. However, in some cases, infusions of paralysis such as rocuronium will be required. As with vasopressors, you should calculate your requirements and ensure you have spare supply. Blood glucose control should also be reviewed. It may be that none is required, and it may be that if you're on a short transfer, that things like rapid infusions could be stopped. Generally speaking, routine feeding tends to be stopped to reduce the amount of infusion pumps and lines required for transfer, but it also decreases your aspiration risk. In E, we think about exposure, so ensuring that any injuries and trauma patients have been secured and that all drains are fixed. We have to think about adequate temperature control, because often the back of ambulances and aeroplanes are freezing cold. Do we need things like electronic bear huggers, or are blankets sufficient? It's also important at this point to think about pressure. Pressure sores have been shown to develop after only 20 minutes on a spinal board, and those are in healthy volunteers. Often we remove blankets and use vacuum mattresses where available. We should make sure that all lines are padded, things like arterial lines, so when patients are secured, there's no pressure over those particular areas. And finally, we should think about any specific equipment that's required. So making sure that you're familiar with all of your equipment, and do you need any additional equipment? So airway adjunct bags, emergency drug bags, which may include things like amiodarone or your cardiac arrest drugs, to make sure that you've got suction, which often needs to be manual suction, and to make sure that you've got an appropriate transfer trolley that can be fixed into your mode of transport. Often ambulances will have their own transfer trolleys that you need to use, and to make sure that there's a power supply for things like your infusion pumps to run off. If you're going on a short journey, ensuring that all your electronic devices such as your transport ventilator and infusion pumps are fully charged, and they're not going to run out halfway down the corridor. It's also really important that you take all the patient's documentation with them for the receiving team, if required. Obviously not required if it's an inter-hospital transfer to places like SCAN, but even going to theatre, there might be some essential pieces of documentation such as drug cardexes that you'll need to take with you. It's also recommended that observations are done every 5 minutes for your vital observations, as well as any significant events and drug administrations on your journey. Most places will copy the patient notes to take with you, and a handover letter for when you arrive. So this can often be what a standard inter-hospital transfer looks like, with your oxylog, transport ventilator, multiple pumps, spare airway equipment on a dedicated transfer mattress. So these are often busy bed spaces with lots of equipment and wires, so lots of potential for things to go wrong. So it's also important to consider your safety and comfort, especially if this is going to be a long transfer. So wear appropriate clothes and layers, make sure you've got the right PPE. That could be anything from appropriate masks for COVID to high-vis jackets that are going to keep you safe at the side of the road. Make sure you take a phone which can communicate with your own critical care department and to where you're going, and money, ID, wallet, that sort of thing. Make sure you know how your staff and your equipment are going to get back. And one important thing to consider that affects a lot of transfer staff is motion sickness, and if there's anything that you can do that's going to make yourself feel better in the back of an ambulance, which may be bobbing around on the roads for hours at a time. So now we're just going to briefly discuss some of the physiology behind transfer and some of the problems that you may encounter on the way. So one of the main problems is the acceleration and deceleration forces that occur by road. And these can cause blood to pool in the extremities, such as the feet, and impede venous return and hence cardiac output. It may be that in anticipation of this, you have to increase some of your vasopressor support, and as we said before, this is often exacerbated in patients who are chronically underfilled or ventilated patients with a high PEEP. Acceleration and deceleration forces can also result in movement of the intra-abdominal organs, which can increase your risk of aspiration through pressure on the stomach and impede ventilation. Remember, these forces also apply to all your equipment and to yourselves, and the safety of you and your colleagues remains equally important. It's also important to consider some of the effects of altitude and to be aware that there will be a drop in the partial pressure of oxygen, which may result in hypoxia, especially if the patient is already hypoxic or has a primarily respiratory pathology. This can be overcome by reducing the altitude of the flight, which should be done in conjunction with the pilot, or by increasing the FiO2. Another feature of altitude worth considering is the phenomenon of volume expansion, which occurs as the bariatric pressure falls. This causes a corresponding increase in gas volume, which means that any gas-filled space is going to increase in size. So all pneumothorax should be drained prior to air travel, and air travel should proceed in extreme caution in cases of small bowel obstruction or recent surgical anastomosis, and road should be considered if at all possible. It's also important to monitor any air-filled equipment, such as ET tubes, as the pressure in this cuff will inflate on ascent, and air might have to be removed and then decrease on descent. And again, if you've got mechanically ventilated patients on high pressures and volumes, this could have significant effects to their ventilation. Other considerations when completing a transfer is noise, which may be significant, vibrations, which can be very uncomfortable for team members and a massive source of fatigue, and handover. So ensure that you have completed any appropriate handover documents and all the important information has been given to the receiving team if appropriate. Remember to get back safely, whether that's a long plane or ambulance ride back well after your shift has finished, or if it's just moving back along the corridor from the CT scanner. So thank you all for listening and for your time. I've left some resources on the next slide that I hope will be helpful, as well as a transfer checklist which can guide you especially on your first few transfers out. Thank you again, and I hope you've found it useful.